So the next speaker is now Professor Dhanny Gomez, HBB surgeon at the Nottingham University Hospital, and he will talk to us about his experience in the CAPBIL study, a UK nationwide surgical audit.
Good afternoon. Thanks to Helen and her AMMF team for inviting me to present the CAPBIL study. So a bit of background, we all have guidelines for the variety of cancers, and for biliary tract cancer, ESMO has produced guidelines, and recently the BSG has also published their guidelines on the management of cholangiocarcinoma. But what is the real world data in the UK? How are we doing? So we first started by doing the first UK nationwide audit on intrahepatic cholangiocarcinoma, and this was published recently. Unfortunately, what this showed was up and down the country in the 4 nations, there was a big variation in practice, in the usage of PET, in the practice of portal lymphadenectomy during surgery, and the administration of chemotherapy. This study was done during the 2014 to 2018 time period. And BILCAP was published in 2018. So Juan gave us the idea to say, how are we doing after the publication of BILCAP? Have we improved in terms of the variation in practice? So what we did was then launch the CAPBIL study. The aim of this study was to evaluate the UK clinical practice on the management of patients with hilar cholangiocarcinoma, intrahepatic cholangiocarcinoma, and also gallbladder cancer. In terms of the inclusion criteria, we focused on the HBB resectional and transplant centers where patients with histologically confirmed resected cancer of intrahepatic cholangiocarcinoma from year 2019 to 22, because we had already done the previous time period. And then we also collected data on hilar cholangiocarcinoma and gallbladder cancer from 2014 to 2022. The outcomes, the primary outcome is we want to know how we are doing. We want to evaluate our practice. We want to see whether there's actually any variation in practice in how we manage biliary tract cancers. The secondary outcomes, we're looking to identify prognostic factors. And as one said to us, has there been a change since BILCAP trial has been published in 2018? For the sake of this presentation, I'm only going to present data on hilar cholangiocarcinoma. So at the moment, in our REDCap database, we have 1,272 patients, of which 395 are confirmed hilar cholangiocarcinoma. This is, believe it or not, one of the largest modern series in Europe. In terms of the demographics of this subgroup of patients, majority are males. The median age of diagnosis was 65 years. The majority of patients present with symptom, and the most common symptom is jaundice. And as explained before, we divided the time period of the study to look at 2 time periods, 2014 to 2018, and 2019 to 2022. I know there are some patient groups here. I hope these numbers would show you that us as HBB surgeons did try to still resect patients with biliary tract cancer even during the COVID period. So I think these numbers does reassure that we did try and managed to still keep our numbers up despite of COVID. it looks like all our patients who are undergoing resection for high local angiocarcinoma have a triple phase CT and an MRI scan. However, the use of PET scan is varied across the centers. What we found was only 36% of patients actually underwent PET scan during the study period. In terms of staging laparoscopy, surprisingly, only half of patients during the study period actually underwent staging laparoscopy. In terms of biliary drainage, as most patients presented with jaundice, the majority of patients underwent biliary drainage either through ERCP or PTC. Regarding PET scanning, so in the current guidelines, ESMO guidelines, and even the BSG guidelines, it is recommended we do PET scanning as one of the preoperative diagnosis and staging for these patients. What we found was, out of the 144 patients that had this, the positive uptake in the tumor was only 48%. And the positive lymph nodes, when I refer here to lymph nodes, I'm talking about portal lymph nodes, only 16% had a positive uptake. So one could argue, is PET scan really required as part of the pathway? So these are just the centers who participated in the study. And as you can see from this graph, if you look at the 50% mark, the majority of case centers, less than 50% undergo PET scan. In some centers, they don't even put PET scan as part of the patient pathway for preoperative staging. When we compared both cohorts, so the lighter blue is the first cohort, which is 2014 to 2018. And the darker blue is the next study period, which is 2019 to 2022. You can clearly see there has been an increase in uptake in the usage of PET. With regards to surgery, the majority of patients undergo an extended right hepatectomy, bile duct excision, and hepatico-jejunostomy. This is usually the standard operative procedure that we use as surgeons. I think the next 2 points are really important. As a surgeon, consenting a patient that is going to undergo such a big operation. So the Clavien-Dindo scale 3 or more indicates significant morbidity. So your chance of significant morbidity is 40%, almost 40%. And that's something to explain to the patient. The 30-day mortality for this operation is 10%. For cases of normal liver resections, we usually only quote 1 to 2% chance of death. With this operation for high local angiocarcinoma, we all know as surgeons it's significantly higher. 10% may be a lot. We previously published the UK experience, and that was single center series from 2000 to 2010. And at that time, the mortality rate was 25 to 30%. So things have improved, but it's still 10%. So I think it's really important that when we consent patients, we explain these figures. The next part is where the differences really exist. in terms of how individual surgeons perform the operation. So the caudate resection, what we call segment 1, was only resected just above 50% of patients. Now the books say that we should resect this as part of the operation. I can understand sometimes the liver remnant we are leaving behind is small, and hence we tend to leave segment 1 because it's located on the left side. In terms of venous resection, looks like around 28% underwent venous resection. Arterial resection, some of us would consider it inoperable, but there were around 20 patients who underwent arterial resection. The other thing that really varies among us is intra-op frozen sections. We normally used to take frozen sections intraoperatively to make sure that the margins were clear, because traditionally an R1 resection margin usually indicates extremely poor prognosis. In terms of pathology analysis, not surprisingly that most of the tumors were early tumors and smaller ones in T1, T2. The majority of them were either well or moderately differentiated. These are your indicators of poorer prognosis. So when I say lymph node metastasis, I'm just specifically referring to portal lymph nodes. And up to 42% of patients had positive lymph nodes. And almost half of this cohort of patients had a R1 resection margin. We define resection margin in two ways. One is longitudinal, and that is surgeon dependent, where we actually transect the bile duct, and one is circumferential, that we really cannot do anything about. That is how the tumor invades the layers of the bile duct. And this R1 encompasses both. And some patients, unfortunately, also had liver metastases that were not picked up on imaging. I just want to emphasize the fact that almost half of patients had portal lymph node involvement. And just go back to what I showed you on the PET slide, where the patients who had PET, it only picked up about 16.7%. In terms of survival data, so this is important for us as surgeons to show whether we are doing the right thing, and important for patients to understand if they're going to undergo such a high morbidity and mortality operation. So we excluded all the patients that had post-op deaths, and we had a median follow-up of almost 2 years. Unfortunately, almost half of patients had disease recurrence. So what we know from high local angiocarcinoma is they do come back. And at the last follow-up, 60% of patients are no longer with us. The median overall survival is 32 months. The 5-year overall survival is 30%. And there is no difference in survival outcome between the two time periods. In terms of disease-free, the prognostic factors we identified were patients who underwent arterial resection, patients who had portal lymph node involvement, liver metastasis, and an R1 margin. In these patients, their disease came back earlier. With regards to overall survival, the larger tumors, patients with portal lymph node metastasis, and whether or not they had adjuvant chemotherapy did influence the overall survival. To put this on a graph, patients who had portal lymph node metastasis, N1, had a significant poorer overall survival compared to patients who did not have lymph node involvement. With regards to adjuvant chemotherapy, so around 395 patients included in this study, only 180 patients actually underwent chemotherapy. This may be due to the fact that a lot of patients had significant morbidity following the operation. So something to consider whether patients are fit enough, not only for the surgery, but also adjuvant chemotherapy. And the most common regime prescribed to these patients were single agent capecitabine. And what we found was that the overall survival did improve in patients who had chemotherapy following their operation. So comparison to pre and post BIL-CAP publication. So if we look at just focusing on PET scan, there is a significant difference in the two time periods. So clearly there has been a shift now that most centers are using PET in their pre-surgery workup. Staging laparoscopy. During the two time periods, unfortunately, there is a significant decrease in using staging laparoscopy as part of the workup. I am not sure why, whether we are trusting our radiology in terms of CT, MRI, and PET more, and hence we think this is a step we do not need to engage with. I am uncertain. In terms of caudate resection, clearly there has been no change throughout the two time periods. Adjuvant chemotherapy. So clearly there has been an increase since BIL-CAP publication that more patients are being referred for adjuvant chemotherapy. So in summary, the important findings. So just to put things in context, this is the first UK nationwide hilar cholangiocarcinoma surgical audit. And what we found is that in all the centers in the 4 nations, there is significant variation in practice for the management of hilar cholangiocarcinoma. We also identified several prognostic factors, such as arterial resection, portal lymph node metastasis, liver metastasis, and the use of adjuvant chemotherapy. And what we did find was adjuvant chemotherapy did improve overall survival. Conclusions. A standardized management of hilar cholangiocarcinoma is required in the UK. We have our guidelines now, but we need to standardize our practice. I just want to say that this study is dedicated to our patient representative, Charlotte Rowe, who was our patient representative for our first study in intrahepatic cholangiocarcinoma, and she was one of my patients, and she has motivated me to continue researching in this field. Sadly, she's no longer with us today. And I just want to say thank you to all my HPB colleagues and all the centers who participated in this first UK nationwide audit. Without them entering this data, I wouldn't have this to share with you today. I would like to thank Lauren Blackburn, who is our data manager who created the REDCap database, and a real special thank you to my co-PI, Jane McClemens, who is in Belfast, who is currently on maternity leave, but she made sure she completed this study and also analyzed the data for today. Thank you for listening.